This conference will now be recorded.
Ken Anderson, do you have anything this evening? You have to put your mic on again, Ken. If you have any, let me know if you have anything this evening you want to talk.
Yeah, Peter, I can, if you guys have time, I can give a little update on BAT.
Okay, we'd love that. Yeah. Okay, this is the first ANCAN advanced recurrent meeting of the year, right? It's the 10th of January. I'm not going to list all the sponsors because if you look at the reminder notice, they're all listed there. But we are very appreciative for all of them. We're getting quite a roster of them actually, and it's a new day. It's a new era when the pharmaceutical companies seem to be recognizing the value and supporting the endeavors of prostate cancer support groups. I mean, we've always known it's a value, but to see them acknowledging this is pretty significant. So we're very appreciative for all of them. Please, if you're not familiar with who they are, Myovant, Bayer, Pfizer, et cetera, you know, go to the list and just make a mental note. And what's even more significant is none of them we're not encumbered to any of them to, you know, other than thank them. You know, we're not pushing products, we're not twisting arms and telling people to go to this drug or that drug or anything else. We're just see the value of it, and we appreciate their support. So that said, we're off to a good start in the new year. My name is Peter Kafka. I'm moderating this from beautiful Maui, Hawaii. No complaints living here, that's for sure. If I did, you guys wouldn't believe me anyway. I'd get no sympathy, which is okay. And if you ever come this way to visit, you know, please take the time to look me up. I know Ken Anderson's going to be here in a week or so. We've met here before, but I'd love to see some of you guys who I've never met before. Find your way to the island someday. It'd be wonderful. Okay, so we have two people.
Peter, do we have any new people?
Yes, we kind of do. Yes and no. Yes and no. They're not really new, but George and Ravi were on the meeting last night, on the low and intermediate one that I moderated last night, and they both have more serious disease and issues. So I kind of told them that we couldn't talk to them last night, but I would give them a little bit of priority this evening and put them on the list tonight. So I'm going to move to George first because he has some, you know, particular issues that are more suitable. Both George and Ravi more suitable to this group than the low and intermediate for sure. So George,
all right,
you've been on this call before, but go ahead and introduce yourself and tell us a little. Well, maybe you haven't been on this call before, but tell us a little bit about what's going on with you.
My name is George Wasilowski. I'm in Wilmington, North Carolina, and I'll give you a quick summary. Started out with a CT scan that indicated that the apex of the prostate was the problem area. Followed up with a biopsy, which came out to be 1.637, and when he targeted the apex, it came out to be 1.8 and 1.9, grade 5. Then did a PET scan. Both the CT scan and the PET scan indicated that it had not left the capsule, and they could not find any cancer outside anywhere else. which was the good news. I also, so the recommendation was to do external beam radiation, first with Lupron, after a couple months, then following it with radiation for 5.5 months, or for 5 months, and then probably following with brachytherapy after 5 months. However, there's an overriding factor, and the overriding factor is that I've developed about a year ago what they called, from a colonoscopy, they found ulcerative colitis, which basically is an inflamed colon. And when it surfaced, it was extremely painful and lasted for about 2 weeks until we were able to get the inflammation down and everything returned to normal. And then when he did the transrectal biopsy, he said might have some diarrhea for a day or two, which that was true, but the colitis returned with vengeance. And for about 2 weeks there, I was treating it again. As I say, it's very painful, but we're able to treat it, get the inflammation down, and everything is back to normal. Which then means if we do radiation, and even if we did the what they called the spacer, there's a good chance that we're going to interfere with the colon. And so that brought up the other idea that maybe we should do the prostatectomy. Although I had a secondary opinion from Duke, they agreed that I need to do something soon. And they also introduced the idea of cryotherapy, which from my reading I find is very invasive, even with the colon. So we came back to the surgery, and perhaps robotic surgery. And so I've been looking at, they do it here in Wilmington, but everyone says robotic surgery depends on the person doing it with his experience. And as the urologist at Duke said, that Dr. Vitt from Vitt Patel at Celebration, Florida, does 1,000 of them a year. Not he himself, he does it for 10 minutes and circulates around the different surgery rooms. But that one that has the most experience, other people telling me that I shouldn't mess around here in Wilmington, I ought to go to the Cleveland Clinic or somewhere else. Which also introduces one other factor. I talked to the radial and oncologist today, and he mentioned the possibility of doing a proton therapy. Proton therapy.
Right.
It's not offered here, but it's offered in Atlanta at Emory, as he's telling me. And that proton therapy is not as damaging.
George, let me stop you there, because most of us are pretty familiar with these treatments. So you diagnosed as a Gleason 9, is that correct? You had 4 plus 5?
Yeah, I had one that was a 9.
Okay, so you are a 4 plus 5, even if it's just 1.
Grade 5.
Go for that. And you're in Wilmington, Delaware.
North Carolina.
I'm assuming you've got Medicare, correct?
Yes.
Yeah. So there are some excellent facilities like Hopkins. I mean, there are some you should.
I'm not in Delaware. I'm in North Carolina.
North Carolina, okay. But even so, in your area, there's plenty of really good places. I mean, other than Duke is great, but you know, you can get surgery probably in a number of places. The trick with Celebration, Florida, you know, Dr. Patel, is I believe you got to pay out of pocket for his services. I don't know if they take insurance. They might. I think our board president, I think he used them a number of years ago for surgery. Bill Franklin, but he's not on the call tonight. Yeah, I mean, there are a lot of very experienced, excellent urologic surgeons around in the DC area, in North Carolina, particularly if you go to a place like Duke, a center of excellence where they just have really good doctors rather than just a small outfit. You don't want that. So, does anybody else want to comment on this? I mean, this brings up the point. I mean, if you've got colitis or issues around the rectum and stuff, you don't want to go with a transrectal biopsy. I mean, the movement these days is going to transperineal biopsies. And I know a lot of old school urologists still do the transrectal, but it can really mess up and do a number on your rectum and internal functions there. So is anybody else?
Comments about proton therapy?
Proton's good. There's a number of people that have done it for primary treatment. You want to get someone who's experienced, a place that really does it a fair bit. There are some people we can put you in touch with at least 1 or 2 people that have done proton for primary treatment, and it's workable and it might be effective for you.
Peter, is proton therapy capable of a really thorough ablation of the prostate? Because if he's not going to be able to have radiation in the future, we want the strongest possible other treatment. And I thought proton therapy maybe wasn't up to the task of total ablation, or am I wrong?
My opinion is that you're wrong. I know of at least 2 guys, possibly 3, that have had proton radiation as primary treatment, and quite a few years later, they're doing fine. One was a Gleason 10, a friend of mine down in Florida, and he's, 4 or 5 years later, he's doing fine. In our Brian Jarvis, in our group, our low and intermediate group, he's in Ohio. He had proton therapy and he's doing fine. If you're on Medicare, it's covered usually by insurance. If you're under 65, it gets a little dicey, but it is covered for you guys on Medicare. But again, you want to go to a guy who's a person, not necessarily a guy, but a doctor who's really experienced with proton.
Thanks.
I'm just coming off of a real bad colitis flare, one that I haven't had in years. And I wish I had the opportunity to not do the prostatectomy and to have proton therapy instead of a complete ablation and prostatectomy. So, and with a Gleason 9, I would skip the prostatectomy and not go through that aggravation and go through all of that. I'd find a radiologist who you're real comfortable with proton therapy, and somebody who can be really, really careful around your rectum. And because I had it both, and I'm in a world of hurt because of it. So if you can find the right guy, it's George, I think, right? George.
Yes.
If you can find the right guy who can work that proton machine, and that's what I would do.
Excuse me, Peter. Do you mean proton meaning a cyberknife, or is that different?
No,
It's
that's
different. It's a whole different
Okay.
machine, a whole different technology.
Okay.
The proton goes to the target, but not through the target. So it's used quite a bit for pediatric brain tumors. Children, because their brains are developing and they don't want to risk destroying their verbal communication or other parts of the brain that are still in development. If a child has a brain tumor, you often go to proton beam radiation because it doesn't have the collateral damage. And in this situation, because the prostate is so close to the rectum, it sits right on top of it. It does have the advantage of going through the prostate and causing much collateral damage to the rectum. So that, I mean, I'm not speaking as a doctor, but that's my thinking. I did it a little bit. I did 10 sessions of it for recurrent disease. I had a lymph node right next to my heart. When they suggested SBRT, I kind of freaked and said, no, I don't want to take the risk of damaging my heart. So I went to proton beam, and it seemed to be. Anybody else here done proton? Anybody on here done proton beam?
Well,
Yes,
I
I
just,
did proton beam in 2019, and I'm a Gleason 910, and I had it up at Mayo, and there was no problem. It was really very simple, and I've had absolutely, knock on wood, no side effects from it.
Oh, very
And
good.
this is 4 years later.
And Herb, you had something, you were going to say something, right?
well, just recently I just had proton sort of to my hips as a backup, right? And I had no side effects.
Yeah, George,
Um,
the one thing is you're going to have to find, you're going to be commuting to this whatever the facility is.
No,
Unless you
I have a
your-
daughter in Atlanta.
Huh?
I have a daughter in Atlanta at Emory.
Okay, well, make sure Emory's up to speed on this stuff. I know Hopkins has a facility. And there might be some other
Yeah,
ones.
I mean, we're not,
Herb?
yes. Well, I think, is Emory up to speed?
I don't know. I don't know that answer.
I mean, Emory's not on our list of sort of places we would send people.
Yeah, so I mean, George, this is your future, your life, and so think in terms of you might have to sacrifice inconvenience or for your future, or convenience for your future. You might have to sacrifice convenience. So even though you have family in one place, you're walking away now.
oh, that's dogs.
Peter, Richard
Even
Wasserstug
though
has
you
his
might have
hand up.
family in one place, it might not be the place to go. You want to check out make sure, ask Duke if they do proton beam.
Okay.
Can I ask why are you so focused on proton beam, George?
The conversation I had today with the radiologist, oncologist, about not being so invasive to the colon, that it is more, that can better target the prostate.
So
Rick,
that's actually not right. The research from 2012, and we can find it and send it to you, and you can send it to your radiation oncologist, is that proton is more invasive to the GI tract, less invasive to the genitourinary organs, and photon is the other way round. So you're getting bad information. I can probably find it right now and put it in the chat window for you. But to be honest, there's very little difference between proton and photon. And as far as Emory is concerned, I think they're okay, but they wouldn't be in my top 10 places if I was going out to look. We've got some people with their hand up, so let me see if I can find that research for you.
Good.
Dr. R.
Can I throw a couple of comments in? And I gather that voice I was hearing is Rick Davis. I was going to say the same thing. So I'm occasionally on here and I recognize names like Lynn and so forth, a few of you, Peter Kafka and so forth. I'm based in Canada. In Canada, we don't offer proton beam. Why? Because we have universal health care. We pay for each other's health care. And unless a new treatment is shown to be better than existing treatments, we don't publicly wish to fund it, or we don't have the resources to fund it. As such, we do not use proton beam in Canada. And our survival rates for prostate cancer patients match those in the United States. However, this is a glib comment, but I'll make a less glib comment to follow. There are people who feel that if it costs more, it must be better. And we have Canadians who do go down to the United States to get proton beam. But at this point, I stand with Rick Davis. What I haven't heard mentioned is using OR spacer, that is organ at risk spacer gel.
Richard, you came in late. He did talk about the spacer, and the beginning discussion was the extreme sensitivity this gentleman has regarding, he has got ulcers.
Colitis.
I know, but I understood that you could push the colon away from the blood. The problem I see is that it's your main tumor, George, is apical, right? So you can't go in with seeding, for instance, because that would be what you do is you go in spacer gel and you go in with seeding to push the organ away from the rectum. And was that discussed at all? And was
Richard
ruled out?
Richard, you came in a little bit late. This gentleman's a Gleason 9. It's rare that they use seeds in a Gleason 9. I don't believe that's common. I might be wrong, but he's got pretty serious colitis issues.
I got that.
I think
the issue, okay, was up here. I'm not sure we'd rule out brachy, particularly if you can get an apical approach, which would be a peritoneal approach with a high density brachy. Was that mentioned to you at all, George?
No. It was just mentioned to start out with hormones treatment followed by radiation. And
okay,
then
I'm just throwing out some ideas.
At the end, I have a choice if I want to do brachytherapy at the end. It will shorten by a half a week, the radiation, if I follow with brachytherapy.
Okay, but there's also the possibility of just going with high dose brachy, in theory. Anyway, thank you. Best of luck.
That an option?
I think the point there, Richard, is that Richard Wassersuch is that they're talking about using brachy as a boost. So he's going to get some pelvic radiation. And George, I found that piece. I just put it in the chat window. Everybody knows, I hope, where the chat window is. It's the little square box at the top right. And I just posted it in there for you now, so you can look at the article afterwards, and you can find the original articles.
All right. Well, now I'm totally confused. Other than continue doing more research, every other day I go toward a different solution between surgery and just throwing my hands up and doing external beam radiation until today, which brought up the idea of proton therapy.
You have a pretty good radiation oncologist that you're talking to at Duke?
Well, I'm talking to him locally. We haven't considered Duke as yet. I'm talking to him locally. I have no idea about his experience.
What do you mean talking to him? Is he at Duke or local? This is a local oncologist.
No, this is the local hospital. The local hospital.
If it was me, I would. I don't know the name of the top radiation oncologist at Duke. How far are you from Duke?
2 hours.
If it was me, I would try to make an appointment and get a second opinion from the top radiation oncologist at Duke, and get them to weigh in, because this is you've got some comorbidity issues here, and the treatment can mess you up a little bit or a lot. So I would for sure get an expert opinion, because whatever you do, you're going to be commuting for some period of time, and I know you could go to Emory if you have family there and so forth, and that might be the place. But since Duke is so close, if it was me, I would get a second opinion from somebody. Does anybody have a name at Duke for radiation oncology that they would recommend?
Yeah, but I do, but I need to look. But I mean, ask Dr. Mould. You've spoken to Dr. Mowell. Ask
Yes.
Dr. Mowell who he would suggest that's as good as it gets. Better than one of our recommendations. He's going to place you with the right person.
Well, with what the comments that David Muslin said about prostatectomy with colitis, seems like I should avoid surgery completely, which leads me down the road to radiation, either external beam or proton.
Well, not necessarily, because there are other options.
What's the other option?
I mean, there are several other options. I mean, there's high dose brachytherapy, which would treat the gland, and you probably would need to follow up with some other radiation, either IMRT or proton to the pelvic girdle. You have options now with things like ViewRay. And these fancy new radiation techniques that they're offering, but they do not they don't cover the pelvic girdle. So for the pelvic girdle, which you probably need given you're a 4+5, there you are restricted to the IMRT. So that the ViewRay would be an alternative to say something like the high dose brachytherapy. Or you go through 3 SBRT treatments or 2 SBR treatments. I mean, now the way that they're treating the gland with a boost, or the pelvic girdle with a boost to the gland, is they're doing it with just 2 treatments of SBRT. That's the state.
What does that stand for?
Okay, it stands for stereotactic body radiation therapy. But I think, George, we need to send you some information so that you can get yourself better up to speed. It's high intensity radiation, where instead of going through 20 sessions, you go through 2 sessions. And now what they're doing is the centers of excellence are offering 2 SBRT, like UCSF and now East. They're offering 2 SBRT, and probably at Duke, they would give you 2 SBRT treatments, which would be great, and then they'll give you treatment to your pelvic girdle, probably 20 odd sessions, and I would do that with photon rather than proton, because proton may have more impact on the GI tract. And I think you've got to get yourself, what the guys have been saying, apologies to everybody for my getting here late today. What the guys are saying is right. You get yourself to a center of excellence. You can't rely on your local guys in Wilmington. I mean, we've shown you that by getting you over to Epstein, and just because you have family somewhere is not a reason to get treated there. Find out where you can get treated, and then we can figure out how you might be able to get the treatment there.
If I can add a comment, this is Chris Carino from Colorado. I did have an executive search firm recommend Western Medical when I was considering proton, and Dr. Bill Hartzell. In fact, they built the Proton Center in Chicago for him, and it's Bill Hartzell at Northwestern Medical. That's the center of excellence that was offered to me.
Okay. Well,
Can I just say one thing, guys? George,
someone had their hand up. Let me go to them, because I can't see raised hands on my computer. So
Jim here.
Jim Marshall.
Hey, George.
Yes.
did they do a scan, essentially a PSMA scan, to find all occurrences within the gland?
No,
You
I
mean
don't.
outside the gland?
Well, doesn't it also show it, in essence, inside the gland?
No, it does not.
Oh, it does not. I didn't know that.
No.
Okay, well, did they do it to show it essentially outside the gland just in case it is escaped and now all of a sudden, okay, it's a monkey wrench?
The scan was the PET scan, the PARPi. The PARPi, is that how you say
Yes,
it?
okay, it is,
Clarify.
and with the PSMA. Then the question number 2, have you had genetic testing?
Yes, high risk. I have a Decipher test. It turned out to be 0.8, which is considered high risk.
So
Okay,
let me clarify for you guys that may
Good.
not be familiar. Genetic testing to people who have been through active surveillance and low risk, for them, they interpret that as meaning the Decipher test, the Polaris test, whether their test is high risk. What Jim Marshall is referring to, George, is testing to see if you have any inherited mutations. Have you done that?
No, I haven't. Grandfather colon cancer, that was the extent of it. No other cancer in the family.
Colon cancer is relevant. Colon cancer is relevant, as Peter will tell you. So what we'll do is we're going to put in the chat window for you the link to the promise. I'll do it momentarily. And that's free. It's done by color. And it's just a spit test. And it's part of a clinical trial being run out of Hopkins and University of Washington. And we recommend you go through that. It won't cost you anything. It's not invasive, and it'll tell you if you have, you could be carrying Lynch syndrome, which could be relevant. Could be. It doesn't mean you will, but it could be. There's a relationship between colon cancer and prostate cancer.
What did you call the stick test?
It's a germline test, GERMLINE, germline or inherited mutation test.
Spit, not stick. Like you spit into a little test tube and send it off.
There's also a link between breast cancer and prostate cancer.
Yeah, there is, but let's not go there right now. We'll get down a rabbit hole if we're not careful. But
Okay,
colon
sorry,
cancer we mentioned because he said his grandfather had colon cancer.
Okay, I'm back in the seat here. I had computer problems here for a second. So
All
George,
right.
we're going to move on.
Go ahead.
Huh?
I have.
Okay.
I've got good notes, and I'll investigate further.
Let us know what you come up with.
Definitely.
The other thing, George, and this is for everybody, is this meeting is recorded, and so you can listen to it again. And if you're signed up to our blog, you'll get a notice of the recording, or you can find it on YouTube, or just email one of us, Joe or somebody, and so you can re-listen to what we've said again later.
All right, good.
Excuse me, Peter. I don't remember hearing that this is being recorded. Is it being recorded?
I believe it is.
Yes, it is.
Yeah, the record's on.
Okay, Ravi, you're up.
Oh, yeah. Thank you guys for letting me speak. I've spoken to this group a couple of times before, so I'll be very brief in presenting my summary, unless you want me to go into more detail.
Read.
Okay, so I had Gleason 9 score cancer, classified as very high risk prostate cancer, but a PSA of 4.7. And what was done for me was I was strongly discouraged from there's a lot of echo coming. Let me just see if I can lower the volume and reduce the echo. Yeah, so what was recommended for me was 38 sessions of radiation. What is it called? IMRT? Yeah, IMRT radiation. And then 2 years of androgen deprivation treatment. So my radiation treatment ended in August 2021, and my ADT treatment is just about ending. I had my last 6-month ADT injection about 5.5 months ago. So that's reaching an end. So I had very little side effects and stuff until about now. Almost 1.5 years after the radiation, I have developed fairly intense proctitis and what do you call that other thing, cystitis. And that's what I wanted to particularly report upon today. The proctitis led to, very frequent bowel movements. There was sometimes I would poop just blood, and they put me on sucralfate enema, which seems to have resolved the problem. But the more intense problem I had, for which I was hospitalized recently, was the cystitis. So there was intense bleeding, profuse bleeding for quite a bit of time. Then it got totally blocked, and I couldn't pass any urine. And eventually, I was admitted at Johns Hopkins, and they did a procedure on me. I was in the hospital for a couple of days, and I'm back now. I just got back a few days back. And the follow-up that I have been suggested is to go for hyperbaric treatment. So that's the latest. I'm in the process of making those reservations, appointments. And I wanted to hear if people had anything to say about the radiation cystitis and the prospect of cure with the hyperbaric therapy.
Anybody this is Len. The efficacy of hyperbaric therapy for radiation proctitis is not as good as when you're using argon plasma coagulation therapy.
I see. But my primary problem for which is being recommended is the cystitis, the urinary bleeding.
Yeah. Okay, can't help you with that. I don't have that experience.
What should I be careful about in regards to hyperbaric therapy? I'm going for my consult on that tomorrow. So what are the questions I should ask?
Well, it can cause cataracts.
One big thing, which they don't talk to you much about, you've got to dig hard on it, is that it can adversely affect your eyes. I believe the retina, not the cornea, but the retina.
Oh my goodness.
And we've known people that have had eye problems. To be honest, I cannot remember. It's a while. I'd have to check. Does one of you guys know whether it's the retina or the cornea? Go ahead, Richard Wasserson.
I had two friends who have had exactly the same bladder problems and have gone for hyperbaric, and both of them have had vision problems and have needed, it's retinal. It can increase your chances of cataracts, and both of them have had to get cataract surgery as a result. Well, I can't say it's a result. There's a correlation in time, not necessarily a causal relation, but it is known, and I know two people very well who have experienced it.
Right, and we've had people in this group who have had that same problem, and they don't talk to you about it. They don't tell you, but you have these eye issues, and then you look and you say, oh, wow, there's some correlation here. As Richard says, we don't know if it's causal or not, but there's definitely a correlation.
So you said retina, but the other gentleman said cataract.
Well, retina and cataracts.
I don't know about the retina, but the cataracts of the lens and the problem to the potential risk of oxidative damage to the lens leading to cataracts is the problem that I know of.
I see. Oh gosh.
However, it's in the literature, and you can ask about it. You can ask about the frequency. So it isn't, you might want to get an eye exam in advance. How old are you? And have you had any?
I'm 64. I don't have any eye problems, but I wear glasses. And I'm beginning to get kind of foggy, so I suspect I may be developing cataract too. My dad had cataract around the same age. So should I mean, so let's say I look up the literature and there's a significant risk of retinal and cataract damage. That then takes me to the point where I wonder if I should, how am I supposed to decide?
All right, I'm no expert in this area at all, and I can't speak to the retina damage.
I don't
know. But for cataracts,
oh,
sorry. Go ahead, Herb.
No, in a lot of medicine, right? I'm not sure you can hear me because my mic is.
Yes, we can hear you.
In a lot of medicine, there's a trade-off, right?
Mm-hmm.
There's no such thing as a free lunch. Mm-hmm. And when you look at the side effects, if you just look at the literature, yes, retinal damage is a possibility of hyperbaric oxygen therapy. Mm-hmm. Whether it will happen to you or not, no one can predict. And how severe it'll be, you can't predict. But you've got to weigh that against the symptoms you're experiencing in your colon and see whether that trade-off is potentially something you want to do.
Mm-hmm. Well,
so the question I have is, we've got a fairly large group today. Mm-hmm. Has anybody in this group, one, had experienced hyperbaric yourself, because we've had a bunch of people that have, or two, has anybody here had cystitis? You can put your hand up or click the hand on the computer, but do we have anybody who's suffered from cystitis? Anybody who's radiation cystitis, that is, or anybody with hyperbaric? Mm-hmm. So whilst we're Mark Finn, so we'll go to Mark Finn momentarily. I have had minor radiation cystitis, but it resolved quickly. Dr. Finn, go ahead.
Yeah, just quickly. I have not experience with hyperbaric, but I do know somebody in my other prostate network who actually had it was more bladder issues that resulted from all the stuff with prostate cancer. And he did go through hyperbaric for that. And I don't know if he had cystitis or not, but I could always put the gentleman in contact with George Guy, put you in contact with him, and if that ends up being a viable option. Thank you.
Ravi, how did they resolve your urinary retention? Did it just go away?
No, they did a cystoscopy, went in and cleared out the debris, and then they zapped. What do they call that term? They essentially cauterized a small area of the bladder.
Oh, they think it was the bladder. It wasn't radiation scarring in the urethra.
Not in the urethra. This was radiation damage to the bladder.
And this was, so the bladder was damaged with radiation from prostate treatment. Is that what you're saying?
Yes, yeah.
Interesting.
Yeah.
Anybody else have any of that experience before? Where did you have your radiation done, Robbie? At
John,
Hopkins?
yeah, Hopkins, yes. And I had this procedure, the cystoscopy, also done at Hopkins. I must tell you, it was quite scary because I wasn't able to pass a drop of urine.
I know that feeling well.
Yeah.
Yeah, that sounds very mysterious to me. That the bladder would get affected so much by the radiation.
Well, it's a geometry issue, and in my case, my prostate is almost. If you look at the MRI, it's almost embedded into the bladder. All right. So the who was it who said that they knew someone who had hyperbaric? I'd like to get in touch with them. Was it Jeff who said that?
No, it was Mark Finn who.
Yeah, I said it, and again, this is somebody who would have experience with doing
So is this where you want that time? Yeah.
hyperbaric. They would not necessarily be
So it's
somebody
7
who
o'clock.
might apply specifically to your issue. But if you get me this information, at least I could. In fact, I'm going to talk to that person tomorrow in our network meeting. I can ask him about that.
So I think that one of our active folks right now, Alan Moskowitz, has had hyperbaric from my notes, and we can definitely put you in touch with him. I'll just tell him he's often on. He's not on today, but what I'm going to do is give you I'm going to send you his email right now, Ravi, in the chat window directly. And you can just tell him that you were asking about hyperbaric, and then you guys can exchange phone numbers and go from there. Okay?
Okay, thank you.
Ravi, if it was me in this situation, I'm going out on a little bit of a limb here because Hopkins has a great reputation. But if you're suffering as a result of radiation at Hopkins and you just went back and they're talking about this hyperbaric, if it was me, I would try to get another opinion from a doc at another institution nearby that's also well known. Just to get some other eyes on this one rather than just to pass it off. But that's just my stance. I might be going out on a limb on this one, but it seems very strange to me.
So question to our guys here. Do you think that Sean Collins might be a good person to talk to?
Potentially, yes, because he does the radiation and he might have experienced it and has connections with hyperbaric. So the answer would be yes.
Who is it?
Dr. Sean Collins, Collins at Georgetown.
Okay.
And he is a prostate radiation oncologist, so he's done a bunch of it. So I'm sure he's seen radiation cystitis.
Okay, thank you. Thank you very much. This is extremely useful.
And he's a terrific guy. He's first rate.
Okay, thank you.
I'll put a link in the chat window for you, Sean, for everybody, and then Ravi, and then you can decide if he knows our group, I believe.
Okay.
If he doesn't, then we've got Herb to blame for it.
Right.
Okay, there's a question in the chat window as to what I was doing for my proctitis, and my response is I did sucralfate enemas. That seemed to have worked.
Anybody have experience with that?
It worked, so I don't have a question.
Good. Okay, Ravi, keep in touch with us.
Thank you. Yeah, I will. I appreciate your help.
Yeah, as I mentioned,
another option on hyperbaric that I've had 12 treatments, and it's not in a hospital setting, but it's outside practitioners that have hyperbaric chambers, and they don't use as high of a pressure. And from what I understand, that you don't have the side effects of affecting the eyes, but you do get benefit of the extra oxygen in your body. So I guess you could just look online for hyperbaric chamber locations. And again, this is not in a hospital setting, it's outside of a hospital setting, so they can't use as high of a percentage of pressure and oxygen. But I found them very beneficial, as has my wife.
Okay, thank you.
Okay, thanks, Ravi. Keep in touch with us on this one. As I said in my reminder notice, we are all N of one. I mean, we are all pretty unique in our situations. And as such, we can't be treated as prostate cancer patients. We got to be treated as individuals with some issues. Find doctors that will listen to us and see us as an individual and not just reach for something off the shelf. So, luck to you. But see if we can get another set of expert eyes on this one, just to take in a little more information.
Okay, thank you.
Thank you. Okay, Chris Carino, you've been on before, but it's been some time or something, or have you spoken to us before?
I have not. I did join one of the meetings. It has been some time ago.
Okay, I'm going to ask you some questions just to get some background. Okay.
Yeah, sure.
Okay. Where do you live, Chris?
Golden, Colorado.
Oh, okay. And how old are you?
63.
And when I'm assuming you were diagnosed with prostate cancer, otherwise you wouldn't be here. When were you first diagnosed?
Right around 2 years ago.
Okay.
And I was a Gleason 9, 4+5, but after my prostatectomy, I was a 4+4. I was a Gleason 8. It dropped.
Okay.
Had the Da Vinci radical prostatectomy April of 2021.
Okay.
And
you did that in Colorado?
Yeah, everything in Colorado, but I would not consider anything here a center of excellence.
Yeah, we know that well. I spent many years in Colorado, and we have a lot of guys on here from Colorado, and we're always working with that one. Kind of a
I'm on my
middle of the country. Yeah.
My bone scan and my prior to surgery, my bone scan and my MRI both showed suspicious bony spots, but my urologist and the surgeon said he and the radiologist at the center I was at thought they were benign. After surgery, my PSA, so I went in with a PSA of 4.7, and I came out of surgery with a PSA of 16.
Really?
And I had an Oxyman PET scan, and it showed 5 bone mets.
Huh.
It found 2 suspicious spots prior to surgery, and then 5 after.
Okay. And this was from a PSMA scan?
Yeah.
Oxyman.
Oxyman.
Yeah.
Okay, Oxyman scan. Okay. And your PSA now is what?
Undetectable.
Undetectable. Okay. And what are you on treatment of some kind?
Yes, I'm on ADT. So I'm currently on Lupron. I had a couple other ADTs stop working, or Govix stopped suppressing my testosterone, and so did Eligard.
Are you on any second line stuff?
Yes, I'm on apalutamide or Lita.
Okay.
And that combination seems to be, so I have about 16 months of undetectable since the hot spots.
And and who's managing your care now? Is it a medical oncologist or
Yes.
still? Okay, we're at the University of Colorado.
Yes. Finally, I was able to. I'm at the university now. I was prior to that. I was at Tuck, the Urology Center of Colorado, and then I went into Rocky Mountain Cancer Center for a med onc, and now I'm with a med onc at university, and I feel like I'm getting better care, but I'm not sure. You made a comment earlier about treating us as an individual, not as a prostate cancer patient. I think they have a tendency to just group you in, in one bucket.
Is this Dr. Kerry, the young woman there? Is that who you
Kessler.
are?
Kessler.
Kessler, no. This is Dr. Elaine Lamb, and she did her fellowship at Ohio State's James under Paul Monk, who I know several of his patients. So I feel like I'm getting Dr. Monk in her, I guess, is my justification for staying in Colorado.
Okay.
I was seriously looking at getting out.
Right.
Ohio is my home state, so but I decided to stay here.
And you have decent insurance at this point?
I
just Medicare yet, right?
I just qualified for Social Security disability. I'll be eligible here in a couple of months, so
Okay.
I'll be on Medicare soon. But yeah, I have private insurance, and when I was with Cigna, they denied everything. At one point in September of 2021, I met with a rad onc here, and she wanted to hit all 5 spots with SBRT, and I got mapped and molded and everything, but they denied it. We had a peer-to-peer, and Cigna kept denying it. So that rad onc just kind of gave up on it. But I was ready to have those 5 spots radiated in addition to the 2 lines of meds.
Well, when you go on Medicare, make sure you go with a decent plan. Don't go with Kaiser or something that's going to limit you. You want to be able to move if you need to with this disease. Even if it was downgraded to a 4+4, it sounds like you want to keep an eye on this thing and get some expert opinions. What are your concerns and questions for the group tonight that you would have?
I was interested in the ARCHES study. I meet with my med onc tomorrow, and I've been, I've had a little bit of discomfort in the bony areas, and even though my PSA is still undetectable, I'm curious how many hormone-sensitive, metastatic hormone-sensitive members might have had good luck convincing their doc to get, and maybe even insurance, to have the PSMA PET scan at this stage.
This is John, and oh, sorry, Rick, do you want to speak?
No, you go ahead, John, please.
Chris, this has been a real hot topic with us for the last week since Len brought it up. I'm particularly interested in it, and we've been debating whether this is going to change clinical practice or not. Even though this study is a couple of years old, like Rick said in one of our emails, it seems to have gone under the radar. One of the authors of this study is my own medical oncologist, and I'm going to bring it up when I see him in February. He gets PSMA PET scans on me even if I'm non-detectable when he has a major change in treatment plan. And it never made any sense to me until we ran across this study. So that's kind of all I have to add about that. Rick, do you want to pick it up?
Well, no, I mean, Dr. John really said what I wanted to say to you, Chris, which is this is really so new and it flew under the radar. Just as a side, I don't. It sounds like you read the reminder. Did you read the reminder?
Yes.
But I don't see you on our database, so I'm wondering how you picked that up.
Yeah, I get the reminders and.
Oh, you do? Okay. Okay,
Yeah.
then you are on our database. I don't see you on the database, so I just put in your name and it doesn't come up. But that's fine as long as you're getting the reminders. So you know, it's flown under the radar. I think I don't know how it's going to change. I mean, I think that we're sort of probably the first group to really uncover it. I shouldn't say we. Len is the first person. Credit where credit's due, Fratello. I mean, I think Len picked it up and mentioned it last week, and it kind of blew us all away. Len, what do you have to say?
Dr. John just mentioned that his oncologist believes in PSMA PET scans, despite the fact that he's undetectable. The Armstrong study kind of was suggesting that you do more of an anatomic scan, like an MRI, a CT scan, rather than a PSMA scan, because I think they were assuming that you were negative on a PSMA scan, and that the reason why you do an anatomic scan is because if the prostate cancer has morphed, it may no longer be producing PSA or PSMA, and the chances are pretty high that if they're not producing PSA, they're also not producing PSMA. So, Dr. John, please ask your oncologist about that. I'd be curious.
Yes, I will.
Yeah.
Yeah, I know, because I thought maybe the study subjects were run before PSMA scans were available. How high is that correlation between being PSMA non-avid and being PSA non-producing? Is that
Yeah.
a pretty high correlation?
I asked Dr. O at Mount Sinai that question, my last visit, and he said he wasn't sure. He said it may be possible, but it's almost certainly very infrequent.
Okay.
I don't think there are any, there's no data on that, John.
So
I have
Chris,
I have another question that I wanted to follow up on that, which is that what about the correlation between PSA and PSMA? I mean, is PSMA present when PSA is not present? It's not something we've really thought about, but see, the reason I ask that question is because if we know somebody's metastatic and they have an undetectable PSA, then a PSMA scan might still show something. But if
That's correct.
So is that possible? Is it possible that you can be undetectable and still produce PSMA on your prostate cells?
For sure. They're
I
different
thought the two
proteins.
were.
They're regulated by different systems. They're not the same protein. So for sure they can be different.
Well, theoretically, yes, but do we have data on that? I don't think so.
I don't think there's data, but they can be different.
I mean, I don't think there's data because I don't think anybody's really studied it. Now, this is a good reason to study it, but I would say that, I had this conversation with Steve Nordstrom last week. Is he on? I came in late, so I don't see if Steve's on or not today because he was going to talk to Shmulewitz. But he said to me, "Oh, well, there's no, I've got undetectable PSA, so there's no point in doing a PSMA scan." I said, "You're right." And then I started thinking about it, and I thought to myself, well, if he has metastasis, and if those metastatic cells are producing PSMA, even though his PSA is negligible, then it should show up. And so maybe there is a reason for people like Steve or Chris Carino to push for a PSMA scan, even though they have a very low PSA.
I'm
Well,
hoping that this topic is going to be updated at the February ASCO meeting.
but I
And
think
that
the evidence, I'm sorry, go
Rick
ahead,
and
Joe.
Herb can, buttonhole somebody and find out if there actually should be a real presentation about it. I hope update.
I'm not sure
I
there will
think
be.
Chris, are you still on?
Yes.
Yeah. Are we addressing your question, or are we getting into the weeds here a little bit for you? What?
No, I think I'm glad I'm getting in at the early stage of everybody paying attention to it, and I am gonna push, and I am gonna I'll get some feedback from my med onc, and hopefully I'll be able to contribute some findings from her being at an academic facility that may be useful for further investigations among this group. So maybe I could be an active participant rather than passive. Yeah.
Good.
Peter, can I just add, the only evidence we have indicates that there is a correlation between PSA and PSMA, because clearly we all understand the higher your PSA level, the higher the chances of your PSMA PET scan being positive, right? So that kind of suggests that they correlate with each other.
That's what I've always relied on in my situation.
No, I disagree with that, Len, respectfully, because I would say that that is when you are trying to find out if somebody has metastasis outside the prostate. So we're trying to see, do you have metastasis outside the prostate? We haven't put anybody on treatment yet, and we're waiting for their PSA to rise, like, say, Tony Fig. And now Tony Fig's on treatment now, but and we're trying to see, is there anything outside the prostate? This is a different situation. This is a situation where we know there's metastasis that exists. And so to say that if you have low metastasis, it may not show up, to me is not necessarily logical. Do you understand? I'm not doing a very good job explaining myself. But I think that we're looking at it from the standpoint of somebody who has metastasis rather than somebody who we don't know if they do or they don't. And there may be a correlation. But in this case, Chris had a PSA of 16. We know the metastasis exists. The question is, does it still exist? And how much is it reduced? And those metastatic cells could be producing PSMA, even in the absence of PSA being present.
Hey, Rick, this is Mike Yancey, and just to comment on that. And of course, in my case, I don't put out much PSA at all, but yet I do put out a lot of PSMA on the scans I've had. So that's just kind of another example of, I think, the point you're trying to make, I think.
Yeah.
Okay, Gary, you've got something to say.
Yeah, I just wanted to say that I had a post-prostatectomy PSA, but had been undetectable for 2 years on ADT and abiraterone, and I had a shot, a quarterly shot Friday, and I asked for an anatomical scan, and I was turned down.
Really?
Well, I would go back and I would show them the Arches study, and I would push. And you have to advocate for yourself here. Who was it? Who was it that
Mike
turned
turned
you
you
down?
down?
Yeah.
Did Mike turn you down?
Yeah. The PA, his PA said she would ask, she was going to give me an anatomical scan, but she said she'd ask about PMSA. And I said, I don't care about PSMA, just the anatomical scan. But she went to Carducci anyway. And he said, no, he doesn't need any scans.
Huh.
Well, you send him that Arches paper and say you think you do. Send him that Arches paper and say, I think I do, Dr. With the greatest of respect, Dr. Carducci, I disagree, and I want a
And
scan.
Gary, when you send it to him, copy me.
Okay.
Okay, and I think we'll turn him around. I just think these docs are not aware of it.
Okay.
Wouldn't surprise me. Wouldn't surprise me. Chris, thanks for bringing this up. It's a great discussion.
I'll ask Dr. Lamb tomorrow if she's aware of the Arches study and just see what she says. I did, by the way, an MRI, full body MRI when she took me under her care back last spring, and it did show those 5 spots being unchanged.
Interesting.
Just one thing, Chris. When you refer to it, don't refer to it as the Arches study. You need to refer to it as the post-hoc analysis by Dr. Armstrong on the Arches study.
Is that in the, what's it called,
Yes.
post? Is that in the reminder?
That's in ASCO Daily, isn't it, or something like that?
Yeah, it's referenced in there, but the Arches study itself is an old study that established enzalutamide. That's not what we're talking about. We're talking about the follow-up analysis that Dr. Armstrong and others did that was published last May, and so they call it a post-hoc analysis. But it's properly referenced in the reminder, Chris.
Okay, thank you.
Okay, I want to move on because quite a few of the guys want to talk, and we're getting down to the last half hour here. So I'm gonna move forward here. Jerry, you were on early. You had something you want to bring up quickly, right? Jerry Pelfrey. Are you not on anymore? There, you're on. Jerry?
Me?
Yes.
No, I didn't have anything else.
Oh, no, Jerry Pelfrey down in Mexico. You had something you wanted to bring up tonight.
It looks like his mic may not be working, Peter.
Okay.
The mic.
Oh, really? John Antonucci, you had an update.
There he is. Go ahead, Jerry.
Go ahead, Jerry.
Okay. I'm asking about iron. I am extremely iron deficiency. My iron score is about 29. So has anyone else run into that where, and I'm having a hard time. I'm taking about 168 milligrams of iron 3 times a day, and I still am not into a good range. So
Jerry,
so that's what I'm asking.
Go ahead, Herb.
You're taking too much. It turns out if you load yourself up with iron orally, you reduce the absorption of iron. You compete with transferrin. And I ran into this problem. I was taking iron a lot and it wasn't going up. And then I got seen by somebody at NIH who's an expert in iron metabolism, who said, you're taking too much iron and you're not absorbing it.
Okay.
So you might want to cut back to once a day.
Okay, but what about they're talking about a shot or an infusion
Yep,
of iron.
that would also, that if you get really low, that's what they told me they would do if my iron kept dropping. They would bring me in and give me iron.
Okay. Well, has anyone else run into this? Because I don't know what's causing it.
Well, that's a point I'd like to make. This is John.
Right.
There are different causes of having anemia. I mean, you can have low iron because you're not taking in enough. You can have low iron because
Or bleeding.
you're not absorbing it. You can have anemia for reasons that have absolutely nothing to do with iron. Red blood cells could be getting destroyed or not being made properly. So a clear diagnosis is really important.
But he says his iron counts are low, so it's probably might be due. It could be internal bleeding. I mean,
Right.
No.
You're in Mexico. You're in Mexico. Do you have medical care there? Someone you can talk to?
Oh, sure. Yeah.
Yeah. If it was me, I would get a workup down there and see if you can figure it out. Get a urine analysis. Just see what's going on, because it could be an issue.
Yeah, that's what I'm concerned about. But as far as my poop goes, it's not black.
Right, but you can have microscopic bleeding in there that doesn't show up in the toilet or visually.
Okay. All right. Well, I will. As a matter of fact, I'm going up to Tucson next week, and I'll have them run. I'll have my doc do it up there.
Very good.
Also, look at your B12.
My B12 is fine. It's right in the middle.
Are you getting enough vitamin C?
Yep.
Okay. Yeah, see a doc up in Tucson rather than us just guessing here, because if it's low, you want to address it, okay? Because it's going to affect a lot of stuff.
Yeah, my endocrinologist is telling me to go get 100 milligrams of iron infused.
Well, yeah, just get some testing done before you start fishing around for the answer.
No, right. I'll have them tested.
Good.
It sounds like nobody else is running into this.
Oh, there's plenty of us that are anemic, but it's not necessarily low iron.
Okay. All right. Thank you.
Yay. John Antonucci.
Well, I just wanted a very quick update. I got my every 3-month PSA. I'm off of hormone therapy now, and my PSA went from undetectable to barely detectable. It's just a tiny little amount. But what made me feel good is that my last summer's cat PET/PET scan came up with a new lesion in my lungs. And my buddy, who has prostate cancer, had the same thing happen. His turned out to be lung cancer. And I got a repeat CAT scan last week, and the thing has disappeared. So that's my update.
Good news. Good.
How long have you been off all treatment, Dr. John?
My last Lupron shot was early July, I think, and it was a 4-month shot. And my last darolutamide was in early August. My testosterone level is still undetectable.
Well, let's hope it stays disappeared.
Yeah.
Yeah.
Nothing scarier than spots on the lung. Yeah. Well, maybe there are a few things scarier, but that's one of them.
Probably be a few more months before
keep
my
moving, because a lot of you.
What's your plan after that, Dr. John? How long are you going to go on holiday for?
Dr. Petrolak says we wait until my PSA is 0.2 before intervening.
Got it.
Okay, we're gonna keep moving because a lot of you have asked to speak tonight. So I don't mean to rush, but we're gonna keep moving. Ken Anderson, tell us about BAT.
Yeah.
We're all ears here, as are bats.
No, I'll make it brief because I know there's a lot of guys that want to chat, but open to questions. I started BAT on Monday last, so it's been 8 days. I got a 400 milligram shot. I must admit I felt better, probably a little placebo effect day after, and the second day after. On the third day, I got a little upset stomach and wasn't bad enough to take anything, and also a little bit of body pain, just overall body pain. But that pretty much cleared up on the fourth and fifth day. So the last 2 days, the energy has really been quite good. So don't know what it's going to do to my cancer. Of course, I went in today for labs just to make sure everything was going okay with my liver, and labs came back perfectly fine. I didn't get a PSA because I got a PSA a week ago, and after my third cycle of cabazitaxel, my PSA went up another 12 points. So all in all, though, I'm feeling great. I must admit.
Very good.
And I think it's so cool that we have someone going through BAT. I'm fascinated to hear, and it sounds like
Well,
you're feeling pretty good.
Paul's got 3 guys at MD Anderson that he's doing, and of course he had to call my doctor locally because he wasn't going to do it in the clinic. He said, no, I'm not doing it. And Paul chatted with him, and he decided he would do it. And he's put it in submitted a request to my insurance company, and they approved 4 cycles. It's a cheap thing, so it's really
Yeah.
not a very costly treatment. But I was surprised they approved an off-label treatment in general.
Yeah.
For the benefit of everyone else, what is bad?
Bipolar androgen therapy. Basically, they throw testosterone at your cancer versus taking it away. It's been around for a long time. Not a lot of people do it. Denmead at Hopkins has been studying it for maybe 3 years, and he's got a lot of data that shows it's pretty safe. Paul 2 years ago said he would never do it, and this year he changed his mind.
So we've had guys, Dr. John, we've had guys do BAT in this group before. Ken is not our first experience. It's been relatively successful, but not durable. So and Ken, we've discussed this. I mean, you expect to get 8 to 15 months out of it, but it does seem to work, and I think that's what they would generally acknowledge. Ravi, if you go to our website and you put in Denmead or you put in BAT or bipolar androgen therapy, Denmead gave us a webinar back in 2017. There are some recent articles. Dr. Antanarakis and Dr. Denmead, and who was the third person in there? There was one other well-known guy.
Mark Markowski is doing it.
Right, and they just published an update on it. So there's a lot of good stuff out there on it right now. And the theory is that the flooding the androgen receptors with testosterone regenerates them, and then they become sensitive to the ADT again, so that it creates temporary hormone sensitivity.
Okay. Yeah, read about it, Ravi. It's not mainstream therapy, but it's out there.
Yes, sounds fascinating.
Herb, you're going in for some therapy this week. Tell us what's going on.
Well, I mean, this is not prostate. And you've got a lot of other guys. Just as you know, I've been complaining about movement and pain, and finally, I went to a neurosurgeon yesterday morning who looked at all of my scans, which other people should have looked at a lot sooner, and said, "You need surgery." for your spinal stenosis. So I'll go in Friday for surgery.
Okay, we'll be thinking of you.
And I just had my last Pluvicto. So how that goes.
Herb, what are
Good.
they going to do? Specifically, what are they going to do on your back?
Fusion.
How many levels?
3 to 4.
You're going to have 4-level fusion done this week?
Yep.
You got no second opinion on that?
Yep.
No second opinions?
I did get a second opinion.
Oh, they all agree?
Yes.
Okay, good luck.
Okay,
This
yeah.
was something that this is dating back 20 years that the chief of neurosurgery at Hopkins 20 years ago wanted to do it because it was so bad. And I put it off and put it off.
Okay.
Yeah,
Okay, we'll be thinking of you.
Yes.
I don't think there's any choice at this point.
Okay. Pat Martin, are you still with us?
No, he had to leave.
Leave. Okay. Rich Jackson, are you? There you are. You're still with us.
Back in active treatment of, I guess, second reoccurrence. Also in a clinical trial for Pluvicto for hormone sensitive, non-chemotherapy treated individuals. So I'm not sure if there's very many folks on this call that actually kind of fit that bill. But it is available if anyone's interested. I'll drop the clinical trial information in the chat window.
Have you started your first treatment yet?
I had first infusion in December. I'll have the next infusion on the 31st.
Okay. Yeah, we know somebody who's doing it out of the country, but great that you got into the study.
The only issue I had on the first infusion was, and again, there's probably not many people our age that wear contacts, but about the third day after the infusion, when I put my eye drops in, they were burning and stinging. It went on for about a week. And that's right now that's cleared up. We'll see what happens with the second infusion.
Rich, if it happens again with the second infusion, we really encourage you to report it. I mean, because it's possible the first infusion, it was something else. Probably not, but it could have been.
I reported it on the first one.
Thanks. Fantastic. Fantastic.
They don't have anybody else that wears contacts that they know of either.
Thanks, Rich. We wish you well and keep us informed how it goes.
Yep.
Okay. Thank you.
X and everything else. Right.
Does anyone else here who's done Pluvicto wear contacts? Herb or Dennis or Mark Finn? Have you had any issues?
Nope, I haven't had any issues. I wear contacts all the time.
Interesting.
Okay, good.
Good. Okay.
Wish you luck, Rich. Mark, go ahead. Since you're on, go ahead.
Okay, good. Thank you. I just wanted to give you an update. I've been on Pluvicto. I've done my first 2 treatments of Pluvicto. The initial result, and really when I started it, I expected that it was going to take me at least 3 treatments before I saw any results. So the fact that the first one was kind of level, and the second one now I've actually gone up a little bit from like a 28 or something to 35. So my PSA is going up a little. My current plan is to continue through the third treatment, maybe the fourth, at least the third, and hopefully the third will show me some improvement, or at least keep everything steady. assuming that that doesn't happen, which I think talking to my oncologist, I'm pretty comfortable that the Pluvicto is just not going to be an effective treatment for me. I'm probably going to go into, I'm right now preparing to go into a CAR T cell clinical trial. It's just a messy procedure. It takes time and effort. There might be some discomfort, but I think that's all manageable. I think it's just the fact of it gets to a point where my prostate cancer, in a much more clear way, is going to start taking over my life, particularly because this particular clinical study, once you get the initial treatment for your cells, then it turns out that uh, you then have to have this activation that's done, and that's done like on a weekly basis, forever. And so, if it's effective, so that's a little concerning because it just sort of disrupts everything in your life, but it keeps you alive maybe. So we'll see. Are people familiar with what a CAR? I know many of you people who we've heard bantering around the academics today. Does anybody else know what's going on with CAR T cell therapy? You want me to describe it real quick, or does everybody know it?
No, I think you should. I
Okay,
think you
just real
should
quickly,
describe it.
what they do quickly, which I've already had done, but I haven't proceeded to the next step. Is step one is they sort of similar to a Provenge. They go in and they put you on a machine. They take your plasma, run it through a machine, and they capture, in this case, your T cells. And T cells are, and you more technical people could correct me, but basically they're part of your um, uh, your lymphocytes. It's kind of part of your whole system that fights off infection. So they take these T cells and then they send them down to a lab. I forget what the lab is anyway, and they mess around with the DNA in them and sensitize them to being able to recognize and then destroy prostate cancer cells. So that part's pretty easy. As far as the extraction of the T cells was very easy. I assume that the genetic modification probably takes some skill. The next thing they do then is I will go in sometime, probably this summer, maybe before, but I'm thinking late summer, and they actually will go through and uh, they have, in order for it to work, they have to make room for these genetically modified T cells. So they'll go through and basically kill a significant amount of my T cells, during which time I'll be particularly prone to infection. I'm not sure how much similar that is to multiple myeloma treatments. I'm not sure what percentage of T cells they kill versus in prostate cancer, but that's what they do. And then after they do that, then they will eventually, after a little bit of time, they then re-inject me with the T cells. The first thing they have to be very careful about, and I think they've learned a lot more from the beginning. I mean, when we first looked at this treatment, my wife and I, it's like it had, several people who died from the treatment. It's like, well, okay, I don't know if I want to die from the treatment. But since then, they've actually developed much better ability to, in the hospital, when you have reactions to the injection of the T cells, that they can monitor it and take care of you as necessary. And then after that, this particular clinical trial works with an activating agent, and then after you've basically shown that your body is not rejecting these genetically altered T cells, then they come in with this activating agent, which actually tells the T cells it turns them on and says, okay, now get at it and go find some cancer and kill it. It's been used pretty a lot, I believe, in breast cancer. No, wait, it's been used in leukemia and some forms of myeloma. And in those particular cases, people they're not cured, but they're pretty significant remission. So it has been very effective, but it hasn't necessarily been shown to be effective for solid tumors. So theoretically, it should be the same technology. The question is whether it'll be able to affect solid tumors the way it affects blood-related tumors or cancer.
And where are you doing this, Mark?
University of Chicago. It's part of I should have had it in front of me. It's part of a national study. I think U of C is going to have it was either 12 to 14 people eventually if they can recruit. But this is one that's a national study. I can send it to Rick if we need to, and we could post it so everybody has a copy of what the study is. It is, so it's, we'll see. I'm not really excited about doing that. I don't like being tethered to the University of Chicago. As long as it works, it's great, but it does tether you. So we'll see how that plays out.
Brave man. You're a
Right.
brave
So, Mark,
man.
who's the sponsor of the trial?
I can, what we can do is, Herb, I can look while we're on the remainder of this call real quick. I should have brought
Okay.
up that paper today. I forgot to. I'll look in my drawer, and if I have it, I'll give you the number and who's sponsoring it. But basically, the company that does the genetic modification, they're a drug company, and they're sponsoring it.
Right.
So I
You say
would
I'm brave.
say,
Really, in this particular case, there are not a lot of arrows left in my quiver, and so part of it's bravery, part of it's desperation. So you just have to kind of go with what the cards you're dealt.
so I would say, echoing what Dr. John said before, it's even more exciting for us to have somebody about to participate in a CAR T trial than in a BAT trial. This is truly exciting for
Oh, come on,
us.
Rick! Don't
And
knock those BAT people.
Um,
Go ahead.
well,
Excuse me.
the reason I say that is because we know BAT can be effective, but we also know it's not effective for that long. And those guys are looking for something like you're doing that will give you a much more durable. So they're doing the BAT whilst, brave folks like you are offering themselves to try and prove out that CAR T is a way to go. So we say God bless you and good luck. I will say one little thing, Mark, because there are guys who will can tell you this, that sometimes it takes two or three sessions of the Pluvicto to see an impact on your PSA.
Yeah, I'm fully aware of that, and you and I think discussed that before, Rick, and that's why I'm saying I was hoping that I would stay. The only thing I was disappointed after my second treatment is that my PSA, which had been stable pretty much for 5 or 6 months, around 25, it went up, and so that was disconcerting, which made me more willing to at least take the next step towards seeing what my schedule might be for
Yeah,
the clinical trial.
but
But if
Mark,
after
the
the
reason.
but wait, after the third one, Rick, if it turns out that it stays stable again, then I'll probably at least do a fourth and see if it makes a difference. But I think once we get to like the fourth or fifth treatment, we're kind of pissing in the wind. It's not going to really work.
Well,
Mark, let me say that the
those
people at
dying
Hopkins,
cells, those dying cells, they throw off PSA.
Well,
So
might
that
be.
that that. But go ahead, Herb.
Mark, the people, I talked to the guy who's doing all the infusions at Hopkins,
Yeah.
and he's done a lot of them. And he says, go the course. He says sometimes it's just up to the sixth that we see it.
Okay. Well, that's a good point, Herb. And
I mean, they were very adamant about that. You can't predict.
okay.
That's
Do you
exactly
know
what
who
happened.
Herb? Can you post in the box or send to me a copy of or the name of whoever the person is you've talked to Hopkins about that?
Yeah, I forgot. His name is Jeff, but I don't know his last. I forgot his
A
last
little
name.
bit more
I'll try
specific
to.
than that would be helpful. I
It
guess
must
I
be a
could go to
bunch of
Hopkins,
Jeffs at
Dr. Jeff.
Hopkins.
Dr. Jeff at Hopkins. Okay.
He's not the doc, but he's the guy that infuses it.
Yeah.
He's the guy that
Mark,
talks to all the patients.
What
that's
does
exactly
Marty?
what happened.
What does Marty? What's his name? The guy that's
Marty
the head chief.
Pomper.
Yeah. What does Marty Pomper have to say about it?
Oh, I didn't ask Marty about that, but I
Well,
can.
yes, I think we should. I think Marty Pomper would be a really good person to ask what he thinks, because doesn't he lay claim to being the originator?
Yep, he is Mr. PSMA, Dr. PSMA. He has the patents.
Okay.
So
Hey,
Mark, that's
Mark.
exactly
How do
what
you spell
happened.
his last name?
Pomper,
Pomper.
Pomper.
And where's he at?
Hopkins.
Okay.
So Mark, different drug, but that's exactly what happened to me on Keytruda. my PSA kept going up and up after, second treatment, third treatment, and my doc pulled the plug after the third one saying it's not working. But lo and behold, before a week or two, 6 weeks after that, it started plummeting. So you never know, and especially when you're dealing with killing cancer cells. I mean, it has a weird effect.
Well,
Yeah.
I think that that's a really good suggestion, and I'll follow up with this Dr. Pomper. And if anybody has any contact details, if you could send those to me, Herb. Rick has all my email details and stuff. That would be helpful, and I'll have that conversation. I mean, I'm not dying to start the clinical trial, but I may be dying if I don't start it. So I just got to figure out
God
what's
forbid.
going to work.
Hey,
God
Mark,
forbid.
it's Dennis. I have a quick question. Is your cancer in the bone or lymph node?
All my disease is about 4 or 5 sites, and it's all in the bone. And I'm considered to be kind of a moderate burden cancer. I mean, that's why Xofigo is a possibility, but my current doc is concerned that I've done a clinical trial which was similar to this lutetium Pluvicto one, and I've done some other things, and he just wonders if it's really good to think about doing more messing around with my bones at this point. So he would be more interested in the CAR T, of which he's a sponsor. I mean, at the UFC, and I'm actually a great candidate for them because I feel relatively good. I'm not like on my last breath, and so in that way, they hope that I can tolerate the treatment. But at the same time, we'll just have to kind of see. But that's why Xofigo really, I'll probably not use that treatment.
We sure wish you well. Keep in close touch with us because this is very unusual. Yeah.
Yeah, that's what my wife says a lot. I'm very unusual.
Another N of one. Yeah, we all are.
But anyway, yeah. So Herb and Rick, if you could send me that information on other contacts, Pluvicto. My current oncologist sometimes can be a little grumpy, so maybe I should just stick with the Pluvicto through all 6 treatments, see where I'm at.
Who is it that who are you seeing at University of Chicago?
Stadler. I'm with Stadler. I like Stadler.
Oh, you with Stadler? Yeah,
He's
I can
good.
see how he can be grumpy.
Yeah.
But I've grown. He and I have grown for a good relationship, so it works great.
Okay.
Hey, Dennis McGuire.
Yeah, hi everyone. Yeah, so when I finished Pluvicto last summer, my blood counts were low, and I was taking a break, hoping that time would heal the blood counts. But as it turned out, over the course of 2 or 3 months, the blood counts actually got worse. The reds, the hemoglobin, whites, and platelets. So we did more testing, and we found that the cancer had spread to the bone marrow. So we did a bone marrow biopsy in the left hip, and there was cancer. So the first theory that Pluvicto was causing the blood count decline was wrong, and it was really the cancer that was preventing the new blood cells from being developed. That was in like early December, and then the cancer was acting pretty aggressively, and the PSA went up significantly. It's currently at 160. So I did a round of chemo the last week of December. I did cabazitaxel plus carboplatin. Had a blood transfusion which helped my reds and hemoglobin. Also had Neulasta, which improved the whites. And I did one blood test post chemo. The PSA is staying flat, so I'm still at like 160. The whites, reds, and hemoglobin are reasonable, but it crashed my platelets. My platelets went down to like 40. So we're just kind of watching that and seeing if they recover enough to do another round.
Yeah.
So
just real quickly, Dennis, what are going to be your other options if you can't get back on Pluvicto?
Yeah, I don't know. I mean, the blood counts have to stay and improve in order to do more chemo or Pluvicto. Beyond that, possibly BAT.
Well, I mean, I guess, the study I'm in, I'm thinking of going into, you do have to have strong, you have to have good blood cell counts. Your blood counts have to be good. But I guess depending upon how you go with Pluvicto, it might be another consideration. Is most of your cancer, is it still bone, or do you have soft tissue issues?
Well, it's evolving.
Okay.
The first 6 years, it was almost entirely lymph node. And then the last 18 months, it's kind of evolved into more bone disease.
So Dennis, when they do the biopsy, when they determine that it's spread to the bone marrow, they consider this prostate cancer in the bone marrow, or is it some kind of leukemia type of thing?
No, it's adenocarcinoma, prostate cancer.
Interesting. Okay.
So, Dennis, I have a question. When we spoke last, you were going to get a second opinion from Dr. Morris on whether to add the carboplatin. I'm assuming he said that was a good idea?
Well, I think, that's a personal decision. It's a trade-off between the pain versus the benefit. Obviously, with the platinum-based chemo, the side effects are more severe.
Yep.
So I kind of went with the nuclear option.
I mean, the reason I raise it is because, I mean, there aren't really indicators. I mean, we suspect your cancer's morphing, but we don't have those indicators per se. And did you send your biopsy to Epstein to see whether he felt that it looked more like neuroendocrine cancer?
No, have not yet. I'm meeting with the doc next week, and we're going to talk about that. The last genetic testing I had, which was in November, everything came back as adenocarcinoma with a new mutation, TP53,
53,
which is
right.
the first time that showed up.
But you see, what my point is that there's no indicator for the carboplatin. So why give you the carboplatin, which significantly can exacerbate side effects, blood counts, and all the rest of it? I mean, are we just like throwing spaghetti at the wall, or is there a reason to add the carboplatin? And that's why I wanted you to talk to Morris, and why I thought send the slides to somebody like Epstein, and he can see what the prostate cancer looks like in the bone marrow, and because you don't have the bandwidth right now to drive down your blood counts, and the carboplatin's going to make it even worse. And yeah, I mean, I understand why you say, well, let's throw both of it, but it may stop you getting more chemo. And we need to know. I mean, I'd love to know from Morris, does he think it's worthwhile getting the carboplatin? Would he give it to you? I mean, yes, no question on the cabazitaxel, no question. But the question is, why are we adding the carboplatin? On a whim?
Yeah.
Probably just in case, Rick.
Yeah, but Dennis doesn't have the bandwidth for the just in case. That's the problem.
Yeah, that's true.
You know,
Well,
because the just in case drives the blood counts down to a point where you have platelets at 40, he can't get any more cabazitaxel. If he just did the cabazitaxel, maybe he can keep doing the cabazitaxel for a while without adversely affecting the blood counts.
yeah, and Rick, I think, those points are well taken. I think the way I'm approaching it is one treatment at a time. So as I come up on next treatment decision, we'll evaluate blood counts, see where they
When's your
are.
next infusion?
It's quite likely that I may not be able to tolerate carbo next time.
When's your next
Just based
infusion?
on
A few weeks?
Yeah, pardon?
When's your next infusion? In a couple of weeks?
It's scheduled for the 17th next week. But that's a placeholder for now. Yeah.
Keep in close touch with us. We feel for you.
So, Dennis, what about VAT?
Yeah,
That doesn't depend on blood count.
I've thought about it. I've definitely thought about it. I'm a little concerned about the aggressiveness of my cancer, that if I go the other way, like if I'm not a responder and I get a flare,
Right.
that could be pretty damaging.
Yeah.
In fact, while you bring that up, those that don't respond to BAT, what do the statistics say about bad responses with PSA flare?
I think there's so few people that have done it that I don't know if there's real statistics on it. Maybe there are, but it's not a very common therapy.
Yeah, while you're talking about it, I'll mention that I put in the comment box the protocol that I'm in for my clinical trial and the sponsor for you.
So that's the big risk for me with BAT, based on where I'm at right now. Not to mention, my top two doctors are not in favor of it, so I'd have to step out and go see Dr. A, which is not an obstacle, but
Well, I'm really sorry so many of you guys tonight are, going through some rough phases here. My heart goes out to you. This is a tricky disease for sure. The doctors are scratching their heads too.
Dennis, Dennis, the trial that Mark put in the chat window earlier, you'll find it there. I mean, that is available through U of C, so you might want to go back to your guy at U of C. I always forget his name. And talk, and talk to him about it.
Yeah, I know. I know experience with clinical trials, regardless of the trial, the bare minimum platelet count is 100.
Yep.
So I've got a ways.
No
I have a ways to go before I would consider that. So.
Yeah, as Mark said, you gotta be a little bit stronger for what he's going.
Yeah.
Clifford, you had something to say. You had a question. There you go.
I just wanted to ask a question about node only prostate cancer, and does that imply that it's only it's throughout the whole lymphatic system, or it's found in only a specific group of lymph nodes?
You want to answer that? I think it's found in lymph nodes.
Yes, anyway, I have only two
Okay.
I know of.
Yeah.
I believe it's specific,
Okay. Okay.
but I'm not an expert at it.
Yeah.
So I think here's what it implies, that the cancer has gotten into the lymphatic system.
Yes.
We can see it in certain places because there are enough cells in those places together. I mean, it used to be there needed to be, was it 4 billion cells aggregated in order to see it show up on a FDG scan.
Okay.
So we can see it for million cells. I'm sorry. But it's probably throughout the lymphatic system. It's just a question of what shows up on a scan.
Okay.
Does that make sense, Cliff?
Yes, because I was getting confused signals when I was initially diagnosed. They said they took out one lymph node that was, of course, enlarged. There was another in my back, and then there was another up here in my chest, right near my clavicle, that showed up. But as I progressed with my treatment, I kept getting the signals from doctors that the cancer is throughout your whole body. So I didn't know whether it was in those specific nodes and they were treating because they took one out, or it was throughout the whole lymphatic system, meaning yes, it's throughout your whole body. So I wasn't sure which it is.
Well, be careful of the word only, node only. I mean, nobody knows. Once it's systemic, once it's in your system, it can show up any place.
Yeah.
So if they say node only, it's a little bit short-sighted. It might be node only right now, but you don't know where this is going, and the doctors don't know either. So
yeah, exactly. So yeah, that's what I was thinking. That they did a bone scan, and my paperwork says my liver's fine, my kidney's fine, lungs fine, things like that are fine. But does that imply it's going to stay in the lymph nodes because I'm on ADT and it's suppressing it, therefore it can't move? I don't know.
Well, as Dennis and Mark are talking about now, I mean, this can be a pretty scary journey, and things can change rapidly and morph, and you just got to keep an eye on it, and lean on your doctors to make sure they're scanning and testing and not just giving you a free ticket.
Yeah, I think that's what I'm going to do is I'm going to really stay with them and continue to do scans, continue to do checkups, and follow it instead of just hey, you're on your next group of Lupron every 3 months and your PSA looks fine. My PSA looked fine for the last 50 years. That's what deceived them. So yeah, I got to stay on top of people because I think they just treat me like every other patient, but I have different things going on. So
yeah, those of us in the Gleason 9 club are in a league of our own. Yeah. It's you just can't turn your back on this stuff.
Right, and I'm definitely one of those Gleason 9s.
So
Peter, do we have more people? Do we have more people on your list?
Yes, we do. We got to keep moving here because I don't want to miss anybody here.
Can I just say before, because we may have to, we've got about another 10 minutes. I just want to say, John Tish, I see your name. I think you're new to the group. Is that right? You're muted right now, John. Are you there? Well, I just wanted to say, if you are new to the group, come on back next week and we'll spend time with you. I don't recognize your name, So if you're new, please come on back. The group will be led by either Dr. John or Herb, depending on how Herb is, but Dr. John has stepped into the breach. Thank you, Dr. John, as always. And Herb may just be choosing to watch from his bed.
Okay. BC Cherry Lady Gmail. Who are you?
So we have that in the chat, Peter.
Okay. Okay. So on my list, I've got Russ Hoover still wants to say something. Mark Valens, Jimmy Greenfield. Who wants to go first here? Who's got something that's pressing? And obviously some of you guys have some pretty serious things. So Mark or Jimmy or Russ, do you have any updates that you want to consider here? Or one of you speak up.
Mine isn't pressing, it's very short.
Go ahead.
It's so short that I'll just take it now. It's my birthday, and I have the kind of birthday present everybody'd like to have.
Happy
Labs,
birthday.
testosterone testosterone 606, PSA less than 0.04. So
well, we'd all like a birthday.
Happy birthday, Jimmy.
That's
Happy
my birthday,
birthday, Jimmy.
Okay, and I'm out because I want to hear from you guys.
Okay, I know a lot of 20-year-olds that would like a 606 testosterone. Okay, Russ Hoover.
Yes, good evening. I just have a quick question. I did a survey today that you guys lined me up for on Talzenna, Talzenna. And does anybody understand what this is about yet?
Yes.
I think it's a
So Talzenna is talazoparib. It's a PARP inhibitor.
Well, and they're talking about mixing it with Xtandi.
Right. So it's a PARP inhibitor. Len, you want to just explain the interaction PARP inhibitors with androgen receptor drugs?
Yeah, well, enzalutamide and talazoparib or Talzenna have two completely different mechanisms of action, and that's why they're considering it right now. Is it a clinical trial, or did they already approve that? It's a clinical trial, right?
I don't know. This is the thing that you guys lined me up with. I spent an hour on the phone with this guy, and I think it was more of a marketing thing than a clinical thing.
Yeah. So they have, that's right, they do have stats on this. I think the combination reduced disease progression by 36% compared to enzalutamide alone. So, and the odd thing is that normally they only use these PARP inhibitors if you have a BRCA2 mutation or something similar. But I believe that in this trial, they gave it to patients even who didn't have BRCA2 mutations, and yet it still showed increased benefit over enzalutamide alone. I'm not sure if they understand the interaction that's causing this, but there's
this is the PROMISE trial, right? Where basically they didn't look at what your MSI or status was. They just gave PARP inhibitors, and they found an effect. And my talking to people and reading is there's a great deal of suspicion about that trial as to really whether it really is the case that if you don't have a repair defect, whether the PARP inhibitors are doing anything. So I think the jury's out.
I was curious.
What Dr. E said, Herb.
Well,
Dr. E said she's going to be presenting data
Yes.
GU ASCO on more wider use of the PARP inhibitor,
All right. Well,
remember?
let's hear what she says.
well, the interesting part is I just Googled this, and evidently it's been out there for 2 or 3 years, but it's been used for breast cancer.
Yeah.
No. Russ, the PARP inhibitor, we've spoken about it a lot on here. It's used frequently if you have certain mutations like BRCA2.
Okay, which I
And
do
we
not
have
have.
guys on here like Carl Foreman who have used it and it worked for a while and they got like 2 years out of it and then they stopped. So the talazoparib it's like a laparib or rucaparib. There are a bunch of them out there. The talazoparib is just another PARP inhibitor. It's not a new treatment.
Okay.
We've discussed it in this
Yeah,
forum many
I'm here.
times.
Okay. Well, I think this thing today, this hour with this gentleman, was more of a marketing thing of questions of, what have you heard? What do you think? And I'm telling the guy, why you ask me what I think? I don't even know what it does. So that was my 2 cents worth. Go on to the next guy. Thank you.
Okay, yeah, ask the guy about side effects for sure and what his experience is with it. Okay, I got Larry Fish and Mark Valens. How about Mark? Go ahead.
Yeah, so the last time I talked with you guys, I'd been on a drug holiday for 8 months and my PSA was undetectable. Well, it's changed. I don't know if you remember, my whole story is I had Gleason 9 with a PSA of 1.1. And I've always worried that they're only using PSA to see if the cancer's coming back. And Mac Roach said that's really all he had to go on. But if the PSA budged at all, then we had to do something. And so now in the last week, my PSA is now 0.02, which is not much, but according to Mac, that's a budge. So my real question today is I'm had a bone scan today. I get a CT scan tomorrow, and I see my med onc on Thursday. I'm just asking you guys: are there any particular questions I should ask, or something special I should be looking for? And then I'll have the results of all these tests by the end of the week. But I just don't want to miss something that might be obvious. If you guys get any ideas.
Well, I think the biggest thing probably with your cancer is there anything that can be sequenced? What was your original treatment? I'm just looking here.
Mac Roach, I had 2 days of CyberKnife and then 6 weeks of regular radiation, and I was on Lupron and then Xtandi for 3 years.
Yeah. There were Mets in your spine. Do we know if they're still there?
Mac went after them with the first radiation, and they haven't shown up again. But we haven't done a whole lot of.
I think if it were me, what I'd be looking for is some tissue that we could sequence, because you don't have. Tim will be out of here in a second. I promise we'll be out of here in a second. Okay. Mark, why don't you give me a buzz and we can talk about it offline?
Okay.
Because we've got to clear the room for the people. But I'll call you tomorrow.
Okay.
Are you in San Francisco right now?
No. We're up at home in Oregon.
Okay. All right. Well, and when are you doing the treatment? When are you doing all these things? You're doing all these scans locally?
Yes.
Okay.
The bone scan is just that was today. The CT scan is the middle of the day tomorrow.
Okay. I'll try and I'm making a note and I'll call you tomorrow so we can create some questions for Halaborno.
Okay, thank you.
Sure.
Larry Fish, quickly, do you have it?
No, we can't. Sorry, we got to get out, Peter.
Thanks,
Larry,
everybody, for your help. I appreciate it.
Okay.
you need one of us to call you, Larry?
No, that's like usual. They forgot about me, but I'm not surprised. Take care, guys.
We'll move you to the front next week.
You'll be number one next week, Larry.
I believe that. Take care, everybody.
It was a tough night for me to get through, you guys.
No, don't worry about it.
I mean, some of you guys have challenging stories. Breaks my heart. Okay, good night, everybody.
Good night.
Good night. Peter, thank you. Thank